A very big hello to all my dear students. So, welcome to the T2O series for your favorite channel, You and I, with Dr. Ruchi Rai. So, how are you all? So, let's discuss another interesting case out here. We are reading together. A 35-year-old male presented with blurry vision. See, this is in red. Middle-aged male patient. Young male. Very important, young male, not middle-aged. Young male, samjho. So, a 35-year-old man presented with blurry vision in the right eye since 1 week. Right? Yeah, sorry. So, blurry vision hai in the right eye since 1 week. The images in his right eye were distorted. What do you call the distorted image? Metamorphopsia, if you remember. He noticed the symptoms several days after starting oral steroids for arthritis in his wrist. There is no history of floater or photopsia, right? You all know, na? Floaters is opacities in the vitreous cavity. And what is photopsia? Flash of light. These are all symptoms going towards retinal detachment. Yeah. So there is no history of floaters of photopsia, no history of diabetes, hypertension. On examination, visual acuity in the right eye is 6 by 9, left is 6 by 6. So there's only mild diminution of vision, but 6 by 9 tak. IOP is normal in both eyes. Pupils are round and reacting. Slit lamp examination, both eye anterior segment is normal. Now coming to the fundus finding, in the right eye, ring reflex at the foveal area is seen. Very, very typical. Young male with a ring reflex at the fovea, history of distorted image, that is metamorphopsia, diminution of vision is not much, it is mild, and history of intake of steroids. What are we talking about? Tell me. Even see the Amsler grid test is showing the metamorphopsia, that is central distortion. Field testing shows a relative central scotoma. What is the most probable diagnosis? What is the diagnosis here? Yes, we are talking about central serous retinopathy. Right? So, guys, you all understand what is central serous retinopathy? How? So, there is a breaking of the outer blood retinal barrier. What was the outer blood retinal barrier? That was retinal pigment epithelium ke strong adhesions. There is a collection of fluid in the subretinal space which is causing shallow retinal detachment. So, first question is on pathogenesis, which you should be very, very clear about. Okay, so just to remind you, I'll just make a quick diagram here to be very clear with you all should be very, very clear with this. Very simple diagram. I think you've seen this diagram if you've attended my classes. This is your retinal pigment epithelium. Iske bahar, this is choroid. This is the Brooks membrane, right? And this is the subretinal space. All these layers are, suppose I'm putting a shortcut here. This is neurosensory retina. So this space is what is called subretinal space, right? So this subretinal space is embryologically loose, and any separation from here is what is called retinal detachment. You should be very clear about this first. Retinal detachment is not detachment of retina from choroid. It is detachment of outermost layer from the rest of it. Let's not deviate from the topic here. What I'm talking about, what is the pathogenesis of CSR? Some problem in this blood adhesion of the retinal pigment epithelium. So outer blood retinal barrier is broken and there is mild accumulation of fluid in the subretinal space, only at the foveal area, not otherwise. And this is causing shallow retinal detachment, right? This is causing, again right here, this is causing shallow retinal detachment, and this shallow RD is what you call CSR. ठीक है ना? Yeah. So what are you looking out here? This is first question on CSR is pathogenesis. Look at this one. What is this? This is the ring reflex that I see. There's nothing but elevated retina because of that subretinal fluid. A shallow RD, what happens? The light of my ophthalmoscope encircles it, which looks like a ring reflex. Okay, what next? We have to keep in mind what are the other questions asked. Amsler grid. So see, this is the distortion or metamorphopsia which can be seen in these patients. Amsler grid is diagnostic in CSR and it is very much diagnostic in ARFT. Don't forget that. Age-related macular degeneration. When you are doing an OCT, what do you see? There is this shallow separation of this is the retinal pigment epithelium. Okay? And this is the rest of the retina, neurosensory retina. Can you see this? There is a dip here because, as I have discussed in the earlier sessions, the thickness at the center of the retina will be less, as it is only 5 or 6 layers of the retina out here. You know? Okay, so this collection of fluid, this is what is typical about CSR. You know, this shallow RD that you can see in optical coherence tomography. What next? Again, this is a repeated question when you do an angiography. What is the pattern? So you're looking out here. What is this? This is ink blot pattern. Correct? And this one is your smokestack. You have to know this. Okay? So this is your smokestack pattern. So the one is ink blot and one is smokestack. Right? Everything is asked. Fluorescein angiographic finding, OCT findings, they can give you in the clinical slide. You should know the pathogenesis. You should also know steroids aggravate CSR. And very important, you should know in acute cases, it is self-limiting. You don't have to treat it. It is only in chronic case that we may need to go for photodynamic therapies, right? When it is really affecting damaging the retinal pigment epithelium and affecting the retina, right? Okay? Okay, so that was all about CSR. Study it properly. Thank you so much. Stay blessed and keep smiling.